Good afternoon and welcome to Health and Living with me, T. Xiao Ik. When we fall ill, mouth ulcers and sore throats are common symptoms that we are familiar with related to things like the common cold and a sore throat. However, if these kinds of symptoms don't heal and go on to become something more serious, one thing you might want to be on the lookout for is whether it could be a sign of tongue, tonsil, or larynx cancers. So how can we make sure that we are accurately diagnosing these cancers? And we'll be speaking to Dr. Balachandran Appoo, Consultant ENT, Head and Neck Laser Surgeon from Thomson Hospital, Kota Damansara, to find out more about also advancements in treating these cancers so that the outcome and the recovery is better for those involved. Good afternoon, Dr. Balachandran. How are you today?
Good. I'm very good. Thank you.
Can I call you Dr. Bala? A bit
sure.
of a mouthful.
Yeah, sure.
If you have any questions for Dr. Bala, you can call us at 03-7733-2900. You can also WhatsApp them through at 018-789-8899, or you can tweet us at BFM Radio. Dr. Bala, head and neck cancers, that while it seems like we're only talking about two parts of the body above the shoulders, I understand that when it comes to the cancers, it can be broken down into many, many different types. Could you give us a very brief overview to help us understand what we're looking at?
Head and neck cancer is a wide field, like going to a room and you see a hall, you see the kitchen and all that, but they're all in the same area, which sort of interrelates, interconnected. Mm-hmm. So head and neck cancer, it starts from let's talk about oral cancer to make it easier. We've got oral cancers, we've got oropharyngeal cancers, and we've got laryngeal cancers. And we've got parts of the upper esophagus, which is called the inlet higher up. And then we've got contribution from the back of the nose. Mm-hmm. And then we've got contribution from the middle ear coming into the nose. And there's so many parts to it. So to talk about head and neck cancer is a very broad field. But looking at the society we have, more often we see cancers arising from oral cancers, oropharyngeal cancers, and laryngeal cancers.
Okay. So oropharyngeal, and laryngeal. So the mouth cavity, the tongue, the gums, presumably.
Yes, it starts from the lips. Lips going inwards, everything inside.
So every single
part of it.
Yes.
Then you can divide it as oral cavity, and the oropharyngeal is behind the pillars of the tonsil, and the tonsil and then going behind to the wall, and then dipping down a bit, the base of tongue, and then dipping down a bit is the inlet of the airway. Every part is divided and named differently, purely for treatment purposes and to identify and to classify.
Okay. And so that's, that's what we want to sort of narrow in on today, that area. And so we wanted to talk about tongue, tonsils, and the larynx. The larynx is the voice box,
yes,
if I'm not mistaken.
Yes, it is.
Yes. Why do you think it's important to focus on these three? How common are they within the context of all head and neck cancers?
These three parts of the this is what we call oral cavity and oropharynx and larynx. These are the parts where people identify it quickly, because you eat, you breathe, and the movement of mouth. All these are areas where people will know that they're having issues. For example, voice box. When your voice goes hoarse, you will know you can't talk very well. So these are important areas where people can identify it earlier, and if they have proper awareness, it will help us and help them to manage.
You've mentioned one of the symptoms, like your voice getting hoarse, and because we're talking about three separate parts of the mouth and the throat, the symptoms could be very wide-ranging, I suppose.
They're wide and they're interrelated. That's the
right.
beauty. For instance, if you have an ulcer of the mouth, first thing is you might feel pain. The pain can be mild. You can manage it. It can become worse as the way days go by. So much so, you can't sort of eat very well. You have pain, excruciating pain at the end of it. You have saliva leaking out because you really can't close your mouth and swallow. Then came the difficulty to swallow, which is initially bearable, and then people tend to feel that they can't eat solid. So they tend to cut down the food, make it more blended, and they go on with that. And then comes the pain, because the nerves, a highly laden area of nerves come into play. Then they start choking. Sometimes if the tonsils or the oral cavity pain is so much, they have pain going up to the ears, going behind. If the tumors are going behind and down to the airway, they tend to aspirate. They drink water, they tend to choke, and the saliva or the water gets into the airway, they tend to cough. And if the voice box is sort of affected by cancer, they lose the voice. And after losing the voice, to regain the voice becomes a chore. It's a progressive loss of voice, plus progressive aspiration. They drink water, they find it difficult. So these are things that sort of encompasses the whole oral cavity, oropharynx, and laryngeal tumors.
Do the three areas? Would somebody get a cancer that crosses over across the three, or do you only get tongue cancer, for instance, or tonsil cancer?
No, cancers are very friendly. They pass to each other.
Unfortunately, the wrong kind of friendly, isn't it?
What happens is the tongue, if you look at it, tongue is not static. It's a mobile segment. It expands, it contracts, it rolls, it folds, and it pushes backwards. So if a cancer arises in the tongue, it can propagate, or in other words, move backwards. As it moves backwards, it can move downwards. As it moves downwards, it moves sideways. So it affects the gums. From the gums, the bone, from bone to the back, to the tonsillar folds, and then it goes to the back of the tongue. So basically, it spreads locally, and if it's extensive enough, it can spread to the vessels that drains these areas, so it goes down to the neck. So it's quite common to have oropharyngeal cancers arising from oral cavity, oropharyngeal cancer, which is behind, going down to the airway. So basically, like I said, they're friendly tumors in a wrong way.
Absolutely in the wrong way. But how long would it take for somebody from the time they first start to develop the early signs and until the point where without any doubt at all that this is it's gone into a severe advanced stage of it? How long would it take, for that to progress? And, at what point do you usually see patients coming in?
It's difficult to say how long a tumor can spread and become bigger. It depends person to person and the intensity or the chronicity. Chronicity means, like, for example, see a cancer of tongue, we call it the 5S, main reasons for cancer of tongue. First is sharp tooth. If you have a sharp tooth and constantly biting on your tongue, it doesn't stop. So the ulcer gets bigger and bigger. So initially it becomes sort of, I can bear it. So you can take a week, 2 weeks, 3 weeks before it becomes extensive where they know that they can't eat. In a buccal tumor, in the cavity of the mouth, if someone chews pan, for example, they already have a very sore cheek to start with. They're used to having sore cheek. So for them to have a tumor growing there, they may not be aware. Airway, in the laryngeal tumors, if the tumor arises, it's very fast because it's a very tiny area, and they will have symptoms arising much, much, much faster. So you're looking at, in a ballpark figure, I would say strongly, 2 weeks to a month, they already know that it's already arising. It's us who are kind of ignorant that we sort of push it aside and say, maybe not, That's the issue that we have in the hospital. Some come very early. At the point I have pain in my mouth, the ulcer doesn't heal. Yes, thank you so much for coming in early. Here we go. Some come in the advanced stage and go, I still don't think it's a cancer. And that's sort of difficult. So the time frame is really, really depends on the patient and the comorbids they have. If it's a first-time cancer or a recurrent kind of cancer, or they have other cancers and spreading there, it's very difficult to say.
I mean, it's frightening because there are people who are prone to getting mouth ulcers, just the normal types, and it's so scary to think about at what point should you be considering cancer. And for many of us, when we have these kinds of so-called vague symptoms, the GP would be our first port of call. What should the GPs be looking out for?
there are few things that you must always remember. It could be a GP or the patient themselves. Anything in chronicity, that means anything that exists and doesn't go away. For example, pain that doesn't go away, an ulcer that's there and is not going away with basic treatment, it enlarges, pain that causing difficulty in swallowing or speaking. These are things that the patient would know by themselves. For a GP, a proper examination with the proper illumination, that means proper lighting, a torchlight, which is good enough, having a look at areas where they can see. Number 2 is to feel the areas which they can see. Beyond that, they shouldn't assume. They should always, if they can't see, they should always send to places where they could be viewed properly.
Okay. We are talking about cancers of the tongue, tonsils, and larynx. Those are one of the many different types of head and neck cancers that can be diagnosed. And we have Dr. Balachandran Appoo, Consultant ENT, head and neck laser surgeon from Thomson Hospital, Kota Damansara in the studio. He's already explained how, because of the small area that it's in our mouth and our throats, cancers like this could appear and spread really quite quickly, and there are certain signs you want to be looking out for, especially when they are prolonged and they keep persisting and they get worse, things like ulcers and swallowing problems. So if you have a question for Dr. Bala, you can call 03 7733 2900. You can WhatsApp 018 789 8899 or tweet us at BFM Radio. When we come back, we'll be looking at the diagnosis, what would be the process of diagnosing them properly, and as well as treatment. And I will be starting off when we come back to talk about the role of dentists, because we're talking about the oral cavity. So stay tuned right here on BFM 89.9. Good afternoon and welcome back to Health and Living with me, T. Xiao Yik. We're discussing cancers of the tongue, tonsils and larynx today with Dr. Balachandran Appoo, a consultant ENT head and neck laser surgeon from Thomson Hospital, Kota Damansara. If you have any questions, please call us at 03 7733 2900, WhatsApp us at 018 789 8899 or tweet us at BFM Radio. Speaking of questions, just very quickly, I want to read out Zaidi's question on WhatsApp. He says he has sinus. One of his nostrils has been blocked for 3 months. Using salt rinse doesn't work. Should he go for surgery? And he says he also has tinnitus.
Hi, Zaidi. To start with the term sinus basically means cavity of the face. So we use it as a general term for rhinitis or flu. When we have a blocked nose, it's usually due to 2 main reasons. One is the hard part, one's a soft part. Hard part is your bone, soft part is your flesh within the nose. Basically, you can call them pillows, you can call them gills. And when they come into contact, they'll cause blockage. Using salt water is usually helpful, but it has a role. For example, if the nose is congested, no salt water can pass through. So putting in salt water doesn't really help. If the flesh in your nose is enlarged because of allergy or over the years it becomes bigger, then you should shrink it down to create a cavity. The creating cavity basically means spraying the nose with any of the decongestant, but be mindful that you can't use it for too long. Once your cavity is a bit open, then you can flush with salt water. But if your nose is absolutely blocked due to anatomical variation, that means your bone is completely bent, your flesh is large, you have allergy for a long time, then the salt water doesn't really work. You really have to go and see a doctor and let them have a look at you. Normally they use endoscopy to have a look inside and explain to you in detail.
I mean, being blocked for 3 months, that's longer than I think what would be considered normal.
Correct. And 3 months is a period where you know that you've been having this, unless it's a one-off or it's been recurring or it's the first time that you're experiencing, then normally things get worse before. It just gets worse and worse and worse. So that will cause 3 things to happen. Number 1, let me explain to you the function of the nose. 3 main functions. Number 1, airway. Airway is when you can breathe through your nose passively without any much effort. 2, when you can breathe, you can aspirate or you can suck in all your mucus and swallow. That means clearance. 3, when you swallow your saliva, your ear pops open. Basically, it's called your tube behind the nose opened up, so you're balancing. If your nose is blocked, you'll have drip behind your nose. It's called postnasal drip, which causes coughing. And it'll cause blockage. Blockage of the ear causes retraction of the eardrum Hence, it causes tinnitus. Then again, it's best to see a doctor, let them have a look inside the nose and see what's going on behind.
That's the hope that answers your question, Zaidi. Best to go and get it checked out. And earlier, when we were talking about the kind of signs that you want to look out for with regard to tongue, tonsil, and larynx, you talked about things like the development of ulcers that don't heal, problems with swallowing until you start choking, and it increases. And I mentioned that GPs would be probably our first port of call and when we want to check out what's wrong. But dentists as well, because it relates to the oral cavity. What is the role of dentists here?
See, dentists, they look at the oral cavity most of the time. So what is the role of dentists purely be looking around for any loosening of teeth, which is not common unless they're old, loosening and bleeding of gums that doesn't heal. Loosening of teeth basically means it could be a localized tumor or even an infection or an aged tooth. If the teeth are on the top layer of your mouth, basically on the maxillary area, they're connected to the sinuses. It could be a tumor rising from the sinuses coming down to the teeth, causing them to be loosened. So this is called maxillary carcinoma. So they can first thing you see is loosening teeth. So the dentist also will have a look at the tongue because the tongue mobility, they can see the mobility of tongue. So dentists play a major role in having a look at the oral cavity where they can see and diagnose things very easily. So they are the frontiers.
And for somebody who is perhaps having some of these initial problems, doesn't really know who to go to, is it all right for them to see a dentist first?
I think most of them who have oral ulcers and they have got painful teeth and gum and cheek, they usually will see a dentist.
Okay. And earlier, you started talking about the 5 S's related to these cancers that we're talking about. You started off with sharp tooth. So if it's causing injury to the tongue. Would you like to further elaborate on those?
Okay. Malignancy of the tongue. Tongue cancers are very common nowadays and people ignore it because they think it's probably I accidentally bit my tongue or the cheek, I accidentally bit my cheek. But let me just explain to you the 5 S's. The common things are very common. The 5 S. Number 1, sharp tooth. I have many patients who come in after chronically biting the tongue over and over and over, creating ulcers that doesn't heal because of chronicity. You repeat the whole procedure of biting and chewing the gum and the tongue. Number 2, spice. Spice means betel nut. 3, smoking. This all attributes to cancers of the oral cavity. 4, spirit. Spirit basically alcohol. 5, sexually transmitted diseases. So the top 5 that everyone should look at. If you have these 5 in your life and you develop ulcers in the mouth, pay more attention to it because it helps us to manage faster.
When you say STDs, does that include the HPV, the human papillomavirus?
Yes, it is.
Okay, so now with HPV vaccination being given to girls, teenage girls, if I have that right, how much would that potentially cut down on oral cancers?
See, the thing is, the studies hasn't been for a long time. We advise people to vaccinate themselves. More than that, I think our social obligation to ourselves and to our spouse and to the partners we have is to try not to indulge in things that is wrong, and doing things which are wrong knowingly may or may not help. So to say, I've taken this, so I'll never get it, I will not say yes to that. I'll probably say, be more mindful to what you're doing. It's more important.
Let's go a little bit into diagnosing, making sure that you are looking at the right condition, diagnosing it accurately. How would you take a patient through that when they come into your clinic and before you arrive at the right diagnosis?
Number 1 is awareness. Just talk to them about what is a cancer, what could be a cancer, what is a tumor. Tumor is a growth. What could it lead to? And normally, things that people can see without you telling them is your neck. When you see a lump on the neck, they get worried. So they ask me, what is it, doc? And you're like, anything that's moving in the front of the neck is usually the thyroid. Anything on the side of the neck where your muscles are, at the lump, they could be lymph nodes, could be something else. But just make it easier. If something is arising from the neck, a simple thing as this. We touch our lip, is soft. We touch our nose, is firm. We touch our forehead, is hard. Simple things for them to know. Touch your lump, is it soft? Feel with your lip. Compare it with your nose, compare it with your forehead. If it's soft, firm or hard. If it's hard, you may want to come early and have it assessed. If it's soft, usually we don't really fear much. You must and should go to the doctor anyway. So this is a thing that classically I explain to them. Like the breast examination, similar concept. Soft, firm, hard. You compare it with your own face. So that's the neck. Anything that is growing big, fast, very short period, is important for them to go and have it assessed. So in examination in the clinic, I usually show them with my camera so that they can see, assess, and know what exactly is going on and the size of the lesion. And we don't press to say, is it painful? No, you never do that. We will know when they talk to you, when the movement of the tongue. So first is assessment clinically. Look at the patient as a whole, and then go to specific areas and have a look. There are many modalities. You can use a camera, you can use an endoscopy to look behind. Sometimes it's limited areas we can go because of pain and they are not comfortable to open them out too much because of difficulty in opening. So we either do it in the clinic as much as we can or take them under general anesthesia. Only we need to have further assessment. Then comes blood investigation to see the comorbids. Sometimes it helps to see the levels of counts that we want to see.
What kind of comorbids do you usually look out for?
A healthy person will have a healthier outcome. If you have a comorbid like you're aged and you've got cardiac disease and your diabetes is poorly controlled, these are comorbids that actually sort of hinders the outcome or the prognosis of a patient at the end of the day. And we look at all these parameters to help us to manage. So we know back of our head that this may lead to that more treatment. And for treatment to happen, we need to give them the basic understanding what we are planning to do for them.
And do you have to biopsy?
Biopsy is one thing that we do, yes. Biopsy is very careful when I say biopsy. It's easier to cut the neck and take out the lump. But it's smarter not to do that because if we cut the neck and take the lump out without having assessed the whole area where the possibility or potential tumor would have arisen, then you go wrong by making an incision on the neck to take out the lump. It's best to first clinically identify, investigation with radiological investigation, CT scans available, contrasted studies available. After doing all that, we know, fine, this is a tumor is limited to this particular area with no other spread. Then we can biopsy if it's small. If it's too difficult to biopsy in the clinic, take them under general anesthesia, make them comfortable, paralyze them, take the biopsy. On the neck, I strongly advocate general practitioners or anyone else who's listening to me, ideally not to make a knife incision to take the lump out as a first step to diagnose that lesion, unless it's specific that we need to do only that. Ideally, a fine needle aspiration would be sufficient to see the spread.
Okay. And, it's again coming back to the use of the tongue, the tonsils, the larynx. I mean, these are so crucial in eating and drinking and speaking, and the thought of cancers affecting these areas. What kind of outlook can you tell patients when you give them this diagnosis?
It's all about the size and how advanced the lesion is. For example, the tongue. The tongue, if the lesion is small, you can excise it small, and they will tell them, look, your quality of your voice may or may not be hampered. But if the tongue has to be partial, half of the tongue has to be removed, we do tell them that, look, you have voice change. But if we can place things to replace the loss of your tongue, your swallowing, you can modify. Eventually, most of them will learn how to swallow. But remember, the tongue is not only for swallowing, it also helps to prevent aspiration because it pushes the food back and pushes it down. If the tongue is partial, there's not enough volume, you tend to swallow and the food tends to slip past your tongue down to your airway without even knowing it. So there's a lot of question about swallowing, speech, aspiration, saliva, swallowing saliva down, your food down without choking. So we tell them that the size of tumor, the advanced stage of the tumor, plus the treatment modality will alter surgically or post-surgery radiation, which also has its own setbacks because eventually it causes early pain, late stiffening. So all these are things that we discuss in detail to patients. So like I always say, early diagnosis, we can salvage so much of the part and we can give them a better outcome.
Is surgery always necessary?
Oh, yes and no. It always depends. Very early tumors, yes. If it's a very advanced tumors, the only surgery we should do is to take a biopsy. Because it's very advanced. We compare the age, the comorbids, and we see that will not be able. We can do, but we shouldn't do because the outcome will be the same. Then why put them through all this? But then again, for example, if someone comes with advanced cancer of the tongue, and halitosis is bad breath, they can't sit in the same room with anyone else. We talk to them and say, look, the outcome of this surgery, which is very advanced, very high morbidity, will give you some quality of life. Basically, if the tongue cancer is so huge, we have to remove the whole tongue, part of the voice box, and we open up the airway out on the neck, and we create a new tongue using a muscle flap, which will give them no bad breath to the people around them, will give them a satisfaction of being able to sit in the public without having them walking away from him or her. But then again, you must inform them that the quality of life will differ if this is what you want, but the life expectancy will not change because the tumor is large. So it's a choice. We have to give them a choice. More than deciding for them, we decide together with them.
So you could remove the whole tongue and then create a new... So that would enable them to continue being able to eat, swallow, drink and all that as usual?
No. A tongue is a mobile segment. When you use a flap, muscle reconstruction, it's a static. You're just forming a platform, a floor in the mouth. Then we remove the airway because a static tongue doesn't move the food backwards. So they tend to swallow it. If they swallow with the tongue not moving or the flap not moving, they'll aspirate. To enable them to swallow, we divert the airway out to the neck.
Oh.
So the windpipe is opened out without the voice box. So now they can breathe. They can swallow like birds. So they have some amount of life left in them. This is all very, very important to know because we have to discuss the family and the patient per se and take a step forward. But in my experience, we have given people a quality where they smile at you and say, thank you, because without much words, they thank you because they can be socially accepted and they can sit around the family, though they don't live longer, but they have the short quality of life.
So you may not be able to prolong survival very much, but you can improve quality in that time that they have.
These are selected patients, not everyone.
Okay. How do you, first of all though, are there other treatment modalities? There's immunotherapy, chemotherapy. Are they used in cancers of the tongue, tonsils and larynx?
Oh yes, see, like I said, surgery is not the only modality of treatment. It is always, in cancer management, it's a combined effort. It's a multidisciplinary approach. When we do a tongue cancer resection, depending on stage, we always refer them to the oncologist where they decide what are the added things they can do. It can be a radiotherapy alone or combined radiotherapy and chemo. And now they're coming up with immunotherapy. All these are important parts of the management of cancer. So no one can say that this is purely surgery. No, this is purely radiotherapy. No. Even for nose cancers, the first thing is biopsy. Then the outcome of the management is best done by the oncologist. So we have to differentiate and be clear on the management side of any malignancy of the head and neck.
Okay, and but you are, a surgeon. So what we will be looking into is as well is how laser can improve the technique of surgery, and I'd like to ask you more about how that helps patients recover. What is the advantage of using laser compared to conventional surgery? I'm speaking to Dr. Balachandran Appoo, Consultant ENT, head and neck laser surgeon from Thomson Hospital, Kota Damansara, and we are discussing cancers of the tongue, tonsils, and larynx. Very small area of the head and neck, but really crucial in our daily activities. And so if you have any questions, do call us at 03-7733-2900, or you can WhatsApp us at 018-789-8899, or tweet us at BFM Radio. Good afternoon and welcome back to Health and Living with me, T. Xiao Ik. In the studio with me today, Dr. Balachandran Appoo, Consultant ENT, head and neck laser surgeon from Thomson Hospital, Kota Damansara. We're discussing very specifically cancers of the tongue, tonsils, and larynx, which can lead to symptoms like ulcers that don't heal and keep getting bigger over weeks, changes in your voice, hoarseness that makes you lose your voice and doesn't come back, swallowing leading to choking and aspiration. And we've already talked about how surgery could be one of several types of treatment methods to approach somebody who has a cancer like this. And of course, alongside, if required, things like radiotherapy, chemotherapy, and even with the advancements now in immunotherapy. But coming back to surgery, we are now hearing about, or rather, lasers is something that you use to treat these cancers. How exactly do they work?
Well, laser is like a tool. It's basically a tool. The tool that shoots a beam, and this beam are very sharp beam, so it helps to remove tumors, areas which were difficult. Example, the tongue base, or even the tongue, anywhere in the oral cavity, or even the neck. It's a very fine tool where we don't touch the patient, so we basically use it to cut in, it's called incision, or we can remove, it's called excision. So where I use lasers for areas which are difficult. In the past, in Malaysia, we all have been trained and we all do lasers for the airway, the voice box. We mount it on the microscope and we shoot down the beam and we remove tumors or tiny tumors from the tiny airway. Mm-hmm. Then now currently I use the similar concept, which is handheld, and I use them to remove tumors with the back of the tongue, areas which I need to excise. I don't use the knife anymore because I find it, but the laser is much more specific and more precision-wise. So I can remove the tumors just about what I want to remove, so I can save a salvage tissue for reconstruction purposes. So my laser technique is basically to have a more precise removal of tumors in areas which are very difficult to approach, unless the other technique is to open the neck and remove them. If it's possible to do anything within the airway, within the oral cavity, in the oropharynx, the area of tonsils and all that. So I prefer laser because it gives me a better outcome, and with the better outcome meaning lesser pain to a fair deal, more better cosmesis, and you can salvage more tissue.
What does salvaging more tissue mean from the perspective of a patient?
It means a lot to them. Every single part of the oral cavity is important in its own ways. The bulk is important for them to push proper food backwards. A tongue volume is so important because it helps the voice, swallowing, speaking, with movement of tongue that you change the voice and you articulate. And with the cheek, movement of the cheek is so important. So if the tumor is large, we remove the tumor sufficient enough to have better clearance, proper tumor clearance. And the laser really works very well. You can go on the areas where it's really difficult to reach. And they are rigid scopes, rigid fibers, and they're flexible fibers, like a robotic. So these are tools that has helped me and to remove tumors in the difficult areas in the up in the oral cavity and the oropharynx, including the airways.
And would you use lasers regardless of any stage that the cancer is at?
If it's a resectable tumor, that means this tumor can be operated upon, I'll use the laser.
Okay. And of course, if surgery is not indicated, is not suitable, laser is, as you said, laser is just a tool for a surgeon, right?
Correct.
Yeah. How about in terms of post-operative recovery? How would a laser be perhaps more beneficial compared to conventional surgery?
The outcome doesn't differ very much because the patient will go through the phases of pain and modifying the lifestyle. What difference it'll make is, like I said, we can salvage more tissue. So the quality sort of changes. We can do away with many things. So, for example, cosmetic-wise, cosmesis more so. If you cut the neck, I use a laser to cut. It gives me a very fine line of incision. So the closure will be very, very fine scar. It helps. To remove a tumor, we don't have to, in my experience, in my personal experience, when I remove tumors with the laser, the healing is faster because you're leaving back tissue which are normal, and we don't cause much scarring. So with all this, the outcome, it can be compared because the patient feels better, faster, and in my whole process of doing all this many years, I feel that the outcome is better, but then again, it's operator dependent.
And what would be the risks of using laser in surgery, that need to be considered by the patient?
Laser is a tool, it's not a toy. It's like a laser, you can cut, it's a class 4. So you can cut through vessels easily with one swipe of your hand. So basically, you need to be trained, years of training, knowledge of the laser, and basically you've got to choose the patients in the area where you operate, and there should be a team of people working along with you. And when you're doing a laser, you need to protect vital areas, especially the eyes. So the risk is operator dependent. If you know what you're doing, there will be minimal risk, if not at least no risk at all. But it's very much dependent on the operator.
And how commonly is laser used for the treatment of these cancers here in Malaysia?
I'm not too sure. I can't speak for the others. We in Thomson, we do a lot of laser surgeries way back from 2009 onwards. We've been using laser for tumor resections and for sinus surgeries. So we do a lot with the laser.
So let's talk a little bit about after the treatment, really, because regardless of whether you use laser or not, a patient who undergoes surgery and perhaps other forms of treatment, there's a process of recovery. And you've talked about, learning to swallow again if a part of your tongue has been taken out. So what does someone need to know? What do they need to expect in going through this process?
When they come to us with a lesion in the tongue, if it's small, they won't have any issues at all swallowing. If it's big enough, they themselves would have experienced difficulty in swallowing.
Already?
Yes, because the tumor is either too big, painful, or maybe fixed. So they know that they've got tongue movement which is impaired and they're having difficulty in swallowing. So we will tell them that portion of tongue will be removed. And then we will have a team of speech pathologists, dietitians, who come along and sit and have a chat with them and to show them how do we do this and what are the things we do in stepwise progression. So they'll be very, very well educated, which is very important, I think. We have to tell the patient what they're going to get themselves into and how they can improve with sufficient help and aid from various groups. So this is how we take them through. So most of the time they're well aware, but at the end of the day, a tumor resection is not a black and white thing. It can go both ways. We may need to remove more than not. And the outcome is always depending on what's the outcome of the surgery and then outcome of the radiotherapy and chemotherapy, which again, like I said, causes prolonged morbidity For example, they get stiffened jaw because of the radiation which is into the mouth. The taste bud goes off, dry mouth. And this acute phase of ulcers, and they can't bear the pain. So if you can brief them what you're going to experience step by step by step, and have the family around them, they will know that they have to go through this process, and they will go through it. And if at some point they get into depression, which is very common because they are unable to do anything, they're going through a process of pain and stiffness and everything changing. A psychiatric evaluation is important for them. It really helps. But more than that is self-motivation and family help.
What about patients who want to turn to some form of complementary medicine? And we know that this is very common in our society. What do you advise patients?
This is a learned population. We call learned. It could be any level of education they have and awareness. It's our duty, solely our duty, to advise them to the point of exhaustion. Because I think if you do not exhaust yourself in explaining everything in totality, need be bringing people around to help understand this is what we can do. We cannot say that the other modality of treatment is wrong. It's not in our good sense of thinking to even tell someone is wrong, some modality is wrong. But we do tell them, this is our portfolio, this is our outcome, this is what's going to happen in this way of management. And if they're adamant, and most of the time they are because they are always in denial, they will go out. And some come back in time, some come back with too advanced a cancer. But we tell them, we cannot hold them back. It's not our right. We do not have the right to hold anyone back. We let them go with a sound advice. And I'm not here to talk about others being good or not, because I do not know the outcome and the studies done.
Yeah, but there's, like you said, there's no denying that they will want to look for options, and you can't stop them from doing that, of course. I just want to very quickly address a question on WhatsApp from Vi, I think, who says, I have a problem of dry lips that has been going on for 2 to 3 weeks now. I have to constantly apply lip balm. After a shower in the evening, it gets so dry that it cracks. Should Vi be concerned?
It's very important to know, but they always say, do not give an advice over the phone.
Yes.
And this has been ongoing. It's a good teaching from our good teachers. When someone has a dry lip running 2 to 3 weeks, you need to know, why are you having dry lip? Is it a local issue? Or do you have a mouth breathing problem? Do you breathe through your mouth all the time, that your nose is constantly blocked? That's the most common thing that runs for weeks. And if you're dehydrated, drinking water doesn't make your lip moist. It doesn't, because moisture of the lip is saliva dependent.
Not water that you consume.
Yes. If your saliva is dried up or less because your mouth is dry, drinking a liter of water doesn't make you have the moisture, because your saliva is different from water. If she has 2 to 3 weeks of dry mouth, I seriously think that she should go back and sit back and have a check. Do I have most common is mouth breathing. Mouth breathing causes dryness. Air-conditioned room with mouth breathing causes absolute dryness, which is ongoing issue for a long time. And sometimes when the lip cracks, then it's become painful lip. Applying lip balm is very good, but to going back to the reason why you have dry mouth is important, because sometimes salivary glands, there are a lot of things to look into. Salivary glands going dry, viral infection of the salivary glands sometimes can cause issues with the salivary glands, but that's not very common to have dry lips. So I think he or she should go to the doctor and actually have a look inside.
Yeah. As always, get it checked out. Also, another question, just very quickly, because we're running out of time soon. This person says, my 11-year-old son had an adenotonsillectomy surgery in 2014. Today, his nose is quite sensitive, frequent sneezing, runny nose. He used to keep sneezing out the mucus, I think, from his nose day and night. Is this kind of symptom unusual in the first place, and what would be the treatment?
I think to start with, the child had the problem before the tonsils and the adenoma were removed. Allergy causes enlargement of the nose and causes blockage of the mucus. The mucus drips backwards, and these are all allergic mucus. They cause the adenoid to swell, and then the backflow causes the tonsils to swell. So the good doctor has actually removed the adenoid and the tonsil to give them airway. But I think the child needs to see an ENT doctor and treat the nose, because nose is a primary source of adenoid and the tonsil being swollen up earlier. So right now they've been removed, fair enough. I think this child needs a nasal spray or any antihistamine treatment before the nose gets totally blocked, because by 18 the face completes and the bone in the nose become hardened, and the flesh is growing every day because the allergy will not stop. So sneezing means you are sensitive. So the sensitivity of the nose causes enlargement of flesh, and this child needs to see an ENT doctor
All right.
for proper nasal treatment.
Okay, all right. I hope that answers your question. And coming back to the tongue, the tonsils, and the larynx, do you have a final message for our listeners?
Don't be in denial, and don't say everything is normal. I don't have cancer. I should never have cancer. I will never have cancer. A tongue ulcer, a pain in the mouth, change in voice, which doesn't get better despite managed treatment. There is no harm in having a second opinion from a professional person. It's no harm. You clear your mind. You are rest assured that you feel better, that knowing that this is not something dangerous. Maybe when you come with a painful tongue, you realize your teeth are sharp. Maybe you can get it sorted out that you won't have the ulcers again. Maybe you find something else which is so small that you can treat and you don't have these big issues that you worry about. So I strongly feel that every person should take their own health a little bit more, make it more special to you. If you know something is not right, come. We are good doctors. We help with a big smile.
And Dr. Bala does have a big smile ready to help. I've been speaking to Dr. Balachandran Appoo, Consultant ENT, Head and Neck Laser Surgeon from Thomson Hospital, Kota Damansara, about cancers of the tongue, tonsils, and larynx. You've been listening to Health and Living on the Bigger Picture, BFM 89.9.
Thank you for listening to this podcast. To find more great interviews, go to bfm.my or find us on iTunes. BFM 89.9, the business station.